begin the panel discussion?
I just want to refresh your memory with the most important, like the take-home message of our today's presentation. First of all, I want to thank all the seminar speakers for doing a wonderful presentations and enlightening us on this current topic. And especially in this week, we have a lot of news regarding RDA and new guidelines. And so I just wanted to bring, before we begin the panel discussion, what was the take-home summary from our talks today. So you have heard Dr. Wojcik's talk, and his perspective was, number one, that vitamin D deficiency is an important risk factor for cardiovascular disease. And if you want to, and also it's a significant predictor for cardiovascular survival. He also presented some data showing that vitamin D supplementation leads to better survival. What Dr. Bhattacharya presented today also confirmed the results of Dr. Wojcik, and also showed that vitamin D supplementation at optimum doses may reduce cardiovascular risk. Whereas calcium supplementation, there was not much data today. So far, it's not compelling. And I was struck by this slide from Dr. Sullivan because it points towards more towards personalized nutrition. One's glove doesn't fit all. So what it says is, like, we have to think about when we're in terms of practicing, it's not just the requirements of that individual, but also a complete picture, like what's the lifestyle, what a person is taking in terms of dietary intake, whether the person is getting enough physical activity. Then these are good because these tell us about preventive or prophylactic measures. Then also we need to be aware as what are the pre-existing medical conditions? Is the individual more at risk for diseases, and whether those can be, or those are like whether a person is deficient. We talked about vitamin D today. We heard a lot about vitamin D and calcium. So whether there is vitamin D deficiency. So we need to do serum levels before prescribing any supplements or any nutrient supplementation. And of course, we need to do those lab values. We need to get the lab results. And the best source of vitamin D is, of course, get out in sun, but also, apply, as Dr. Wojcik said, you have to be very cautious about cancer risk. And so based on that, I would summarize that, and also in light of the recent report from IOM, that we need more additional data or analysis, which is coming, as our speakers today pointed out. One of the concerns with IOM is that it's a very conservative group. And we are talking about healthy individuals, not about individuals who already have some kind of a medical condition. So we need to come up with stronger trials in terms of the randomized controlled clinical trials, and study the effect of nutrient alone or in combination. So we need more data or analysis from such studies. And two recent such randomized controlled trials this year have come up. And this is very recent, which is published in the Journal of Bone and Mineral Research, and has shown that calcium supplementation as high as 1,200 milligrams per day did not increase the risk of atherosclerotic vascular disease. So it means that people can still be using calcium supplementation and not worry about this vascular calcification. And then Manson's, this is from Women's Health Initiative, which was published in Menopause Journal, and it stated that postmenopausal women with 1,000 milligram of calcium and vitamin D, which was 400, did not alter the prevalence and quantity of coronary artery calcified plaque. So, this slide you have seen repeatedly in one form or the other today, and it basically reiterates about what IOM, and actually I combined even the recommendations of ACE, American Association of Clinical Endocrinologists, here too. But what it points is the safe level so far, according to IOM, is 20 to 50 nanogram per ml. And whether these effects are sufficient enough for these levels are sufficient enough for its effect on other beyond the bone health effects still remains inconclusive, and more research is needed in this area in terms of randomized clinical trials. And again, the emphasis should be, during your practice, some patients would definitely be needing more vitamin D levels, like in the range of, we heard Dr. Wachek and Dr. Bhattacharya say, like they could be needing about 1,000 to 2,000 IUs in order to get to that 30 nanogram per ml levels. So once again, we need to stress on lab values, individual serum tests, serum levels of 25-dihydroxy D3. And then Dr. Sullivan did a very good job in explaining, the sources of food sources of calcium and vitamin D, and these are some of the numbers. And those of you who have given the reference here, so if you haven't looked at it, I would encourage you to please take a look at this report. So my role, I'm a vitamin D researcher in the Department of Dietetics, so I'm interested in, and actually Dr. Wachek in one of his slides had mentioned about how the mode of action of vitamin D. So actually vitamin D receptor of late is beginning to be known as the age-well receptor, because it has a role in cardio, not only in cardioprotection, but also in all those aging maladies which is associated with it, because vitamin D, it interacts with vitamin D receptor at an intersection between bone, vascular, renal, and endocrine axis. And today it was very clear from today's presentation that vitamin D has effects not only on bone, kidneys, vascular functions, etc. So how does vitamin D receptor do this? It's through the control of certain genes, and namely, I've listed the number of genes, but what they do is, this receptor does is it regulates these key genes. For example, the genes which are important for maintaining bone, good bone, or in terms of good bone means the fracture-resistant bone. So those key genes include, this is bone glab protein, or osteocalcin, osteopontin, LRP, RANK ligand, and OPG, osteopetrograde. And all these allow the formation of highly resistant, fracture-resistant bone. And this is important for bone health, like preventing osteoporosis. Then we have the vascular effect. We don't want to build up excess of 125D3 in the system. So how does in vivo, how does the body take care of it? And that body in vivo, we have a very good system which is vitamin D regulators, and these are FGF23, which is a phosphaturic hormone, and that's where the kidney comes into play. And its receptor, which is called as CLATO, and the presence of this catabolic enzyme, which is CYP24 hydroxylase. And so a combination of these genes, the regulation of these genes would help in balancing 125D levels in the body. And finally, the calcium and phosphate homeostasis, which is by induction of calcium genes, like TRPS calcium channel genes, and phosphate transporters, and which are important for mineralizing the endoskeleton, optimal mineralization. So this combined activity of vitamin D receptor in terms of acting at the intersection of bone, kidney, and heart plays a very important role in mediating vitamin D effects, pleiotropic effects of vitamin D. So with that, I would now invite our speakers to the podium, and it's open for a discussion.
Well, I can take part 2 easy. Hypertension is a risk factor for coronary artery disease. That's a solid one. I'm not aware of the data or background on interaction of dairy product intake, calcium intake, and hypertension. I mean, some of the medications we use to lower blood pressure, the calcium antagonists, they really work at the cellular level to block uptake. But, you know, there may be information out there. I'm just not familiar with it. I don't, and we usually don't restrict our patients' intake of calcium, even if they're hypertensive. You know, I'm thinking of the number of people that we have on calcium supplementation and whether there's any relationship between their supplementation and hypertension. I don't think so. I think with your suggestion, I might analyze our data to see if I can correlate that at all. But are you proposing that it's dairy products specifically that carry the risk, or total dietary calcium intake?
No, he's talking about the DASH diet. So he's actually saying dairy products are productive. So if you're familiar with the DASH diet, which was a controlled feeding study published like in 1989 or something, they had, you know, it was a multi-center across the country, and there was one group of people that were randomized to, they got the typical Western diet, and so on all their foods were actually fed to them, so they really knew what they were eating. And then you had another group that was randomized to a low-fat diet, but high fruits and vegetables, and so they're and you know, kind of the first step, low, kind of a heart healthy type diet. The third group got the high fruits and vegetables, the low fat, but they also got 3 servings of low fat dairy food a day. I forgot to mention they also threw nuts into the groups. So the difference between the 3 groups was, you know, the typical Western, high fruit and vegetable, low fat, high fruit and vegetable, low fat, and 3 servings of dairy a day. And the group that had the 3 servings of dairy a day saw this most significant drop in blood pressure. So as a result, you know, they recommend like the DASH diet for people with high blood pressure, or actually the dietary guidelines recommends the DASH diet, and the new food pyramid that came out in 2005 really is the DASH diet. So that's where the 3 servings of dairy food came from. So the dairy food really was protective in lowering blood pressure. Is that what you were asking about, Pete?
Going back to Dr. Sullivan, is for healthy people, food is safe, and also makes very safe holiday gifts also.
She was asking about the role of magnesium. And yeah, clearly magnesium, you know, has got evidence associating with, you know, lowering blood pressure in particular. And magnesium is a great nutrient. Another nutrient that's kind of one of our, not true shortfall, but, you know, kind of those at-risk nutrients. And a great reason that, you know, to me, the package of nutrients from dairy food is so good is because it actually does contain magnesium.
I'm actually doing a study, and what happens is with magnesium, it is in a cellular level, what it does is that it increases the production of PTH and also increases secretion of PTH in individuals. So what we see is in our liver transplant patients is these individuals who have low calcium, low vitamin D levels, but their PTHs are not elevated. That is consistent with secondary hyperparathyroidism. It doesn't make any sense. So our thought process is that it's the magnesium deficiency that's causing it. And we're having a lot of trouble recruiting for that study. But beside that, that's been shown that it is a regulation of the parathyroid hormone.
No, Julie, I think that's a good point, and I agree. In the points or the populations of interest that were described in the IOM document, they mentioned that those people adiposity may be a special population that ought to be considered for altered recommendations. It's real clear there's a linear relationship. The higher your BMI is, the lower your vitamin D measurements are, and those people, to get to therapeutic range, however you might, or normal range, however you might define it, are going to need more per person, maybe not more per pound, but I would think that would be the next step in this, that the dosage recommendations ought to be adjusted for weight or probably BMI. So that's a great suggestion. That's another thing we can maybe examine our detail to see if we can break maybe weights down in deciles or quartiles and see if there's a relationship there. But I would say that, you know, you could say that we should make alterations in the amount of time you spend indoors, maybe job description, you know, Chilean miners, they're going to need more vitamin D than folks who are picking chili peppers in Alabama. So yeah, you can understand why the IOM does what they do. They're trying to allay concern that there's a rampant health care crisis in this country, that somehow we've missed this, the medical profession has missed this terrible problem. But it's a very conservative overview, I think, and you know, hopefully in the future we can define maybe more realistic categorization of folks who would benefit from enhanced supplementation. And you know, they're getting pretty close. I mean, going from 400 to now 600 in general, 800 greater than 70. I think it's going to keep ratcheting up.
Hey, what? If you take this, I'll pass it. Any questions, just hold your hand up. I'll get the mic.
Let me ask how many of you folks, how many people are here taking calcium supplements? How many are taking vitamin D supplements? Yeah, well, you know.
I just wanted to point out that, yeah, we'll be selling vitamin D supplements as you exit today. Not really, but don't you want to rush out and buy some now?
I listened to the webcast on Tuesday that the IOM did, and it seemed like a lot of their discussion centered around, they were concerned about the validity of the labs and the measurements. And I just wondered, how big of a concern do you have? Because they just felt that it was really, I mean, that was my impression.
I can address that. Are you talking about 25-hydroxy-D?
Well, they were wanting to use the 20.
Yeah, but the 25
a lot of variability, and that's why they used the
Yeah.
20. They didn't feel comfortable using a higher value.
The 25D, yeah. So they're yeah,
Nanograms.
yeah, for 20 nanograms for the 25 hydroxylated vitamin D level. So what happened is there is some issues, but the problem is it's a lot of academics, and these things, the industry is correcting itself. So what occurred is that they sent blood samples of several different labs, Nichols, the KU Medical Center, Mayo Clinic, and all these other places. And then when they compared it to the gold standard, which is the mass spec, before it was diazorin, but the mass spec evaluation of 25-hydroxy-D, that there was too much variation between Nichols and Quest and this, that, and the other thing. Well, that is correct. And then what happened from that was diazorin, which is a company, did the labs show that they were closer to the gold standard, which is mass spec analysis. But now what's going on is that I know Quest, which is our major lab place, and Mayo Clinic have moved on to mass spec. And since they're using it more and more, the cost of the lab goes down. So I think that the industry is correcting itself in terms of the levels. Here, we do send, we don't do mass spec in everyone, but in, if it's a send out, if it's a private insurance, it is done mass spec.
Good morning. For the panel, thank you for your research findings and sharing that information with us. I kind of have some food for thought and would hope to get some of your comments on it. Similar in the vein of our question before about special populations and how we know African Americans or individuals of color have a natural SPF and that we're not able to synthesize the vitamin D the same. And so my thought is, given that the African Americans have a higher rate of high blood pressure and diabetes, and that there could potentially be some issues because of the receptors in the body responding, that those levels have to be much higher. And I can share personally, I'm currently taking 2,000, and that really came out of my trip to Boston and meeting Dr. Hollick. If you're familiar with his work, he's pretty radical. And I will also say to that matter that I have a mother who is currently taking 6,000, and she states she's never felt better. So, comment.
Well, I think that a population of interest, and certainly as the IOM guidelines suggest, and that's in this country, as in, it's an international community now. There are, be it a black background of Asiatic Indian, of Native American, Hispanic. To me, the benefits of adequate supplementation in all groups, particularly recognizing the problems with absorption and conversion in populations of color, the burden is really to emphasize adequate supplementation rather than give a public impression that there's something that we're trying to pull over on the public, that it's dangerous, that there's risk associated with it. I don't think any of us are advocating that everyone gets 10,000 IU units daily. Maybe not that everybody gets 5,000. If you're demonstrated, though, there are some people who take 1,000 or 2,000 who will not get to a particular range. And if you say 30, you're going to miss more than at 20. But even so, there are people like your mom who will benefit from 5,000 or 6,000. Now, the treatment of hypertension or hyperlipidemia, I have both myself. I don't feel any different whether usually my blood pressure is normal or not, or my lipids are down. But I've heard the same comments from people that they do feel a better sense of well-being. And, there's placebo effect from taking supplements, from taking stuff, but there's something to the vitamin D thing, particularly in people who were clearly deficient. Yeah. And I think those people who are at 8 or 14, that if you can get them above 30, I think that there's a difference in many cases. That's subjective, but I think your point is a great one. And unless you deal with a bunch of, with white retirees in Miami, I think we just have to be more aware of the necessity of population-based evaluation and consideration for supplementation programs like my last slide said. But that's a great comment, and that personal anecdote that extends to a lot more patients that we see.
I think the other thing is targeting to a level, not to a specific amount. And so there is a publication that's, I'm not sure if it's in press yet, looking at African American children and rates of vitamin D deficiency. That was from my former institution, University of Pittsburgh, so you might want to, I forgot the name of the author, but he's publishing that and looking at African American children and seeing profound rates of vitamin D deficiency. And he's a pediatrician, so it'll be a very
I have a question. Given the number of things that can influence vitamin D status that have already been brought up, like skin pigmentation, age, body weight, stage of pregnancy, and so on, I'm wondering if you, too, because you represent different medical specialties here, have any thought about whether we should just start recommending a test of vitamin D status for everyone in terms of measuring the 25-hydroxy and what you would think about that. I mean, the Food and Nutrition Board is obviously not in a position to do that, but do you see that happening in your specialties, and do you see that maybe extending to pediatrics and other areas?
Yeah, well, I'll tell you, my awareness was really raised when I saw my patients coming back from the internists here at KU and at the Westwood campus and at KU Midwest, with them already having had vitamin D levels drawn. Now, that was maybe a selected population because they likely had cardiac disease, and that's why I was seeing them too. But it was really the internist here who raised my awareness from a clinical standpoint. And then I talked to folks like Raj, I talked to folks like Jason Stubbs in nephrology, talked to folks in other areas of allied health, and there seems to be a groundswell of interest and involvement with this. So that's really what got me fired up. So I would agree with you that this is something that crosses any specialty guidelines, and just the fact that you're having this conference here means that there's a broad base of interest and concern over. If this was something that you could market or patent, your comment before about selling it out, if you could charge $10 a capsule, there would be a ton of studies. This would be promoted all over the place, but you can't patent vitamin D now. It's cheap, it's ubiquitous, so there isn't the industry drive that gives it the push like it does for some of this stuff, right? And I think that's part of the problem. Can I get a grant to study this? Probably not. Can Raj? It's gonna be tough. There just isn't the money to support something like this. But it truly is something because it's been in there. It's been, you can't bill for it to a great degree. The test has been expensive in the past. Yes, there has been inconsistency in the measurement methodology, but that shouldn't dissuade us from recognizing that we've missed something over the course of time and pursuing it fairly aggressively. That's my answer to your question.
Okay, I had a question. You just glanced over it real fast. Have you seen any major difference between the fish oil in the natural form and then giving vitamin D3? Patients' absorption and utilization.
You mean if you got...
If you got it from the natural source, or you got the vitamin D3.
There's no vitamin. Cod liver oil.
The cod liver oil. That's with vitamin D. The natural vitamin D. The natural vitamin D.
I don't think I work on omega-3, so I'll just comment that this is something people are misinformed about. Fish is a good source of vitamin D, particularly ocean fish, but you're not going to get vitamin D from your fish oil capsules. So if you're thinking you're getting it from that, you're probably not.
No, it's specific vitamin or cod liver oil that has vitamin D, that's high in vitamin D.
And one of the problems, I haven't looked at cod liver oil in this country for a while, but we have stripped, because cod liver oil is so high in vitamin A, there was a lot of it that's marketed in this country is stripped of those fat-soluble vitamins. I don't know, I'm not saying there isn't a source, but if it says it's got vitamin D, then it does, but I don't think there's probably enough of these products around that people would have any data on it.
I'm not sure I'm not aware of any data looking at it, and I don't have any data.
The molecule is the molecule. D3 is D3 wherever it comes from. Likewise, D2. So I'm aware of the implications when you say natural or organic, and the fact that the evil pharmacology industry has made unnatural analogs to the things that we used to get in nature, but these are not complex molecules compared to some of the things we take, and I don't have any concern at all that the supplement source has a dramatic difference in outcomes. I will tell you personally, just like your mom, when I started taking supplement in my capsules, my level went from 22 to 38 very, very quickly. So it's effective in raising levels, and I don't think that metabolically the cells care at all where that molecule came from.
My question is to Dr. Wojcik. In your study, what was the PTH status for the individuals? Did you look at the PTH status?
Don't have that data. The vast majority of those people did not appear to have a PTH drawn, and if I was going to analyze it for people who had it, we would have decreased the number so much that the validity of the analysis might have been in question. That'd be a great prospective thing, and that's maybe where you could try to get a grant from this. I think if you could tie vitamin D research into some other endocrine or renal thing, the impact on dialysis patients. But just to study vitamin D, I think it's going to be tough to get grant support, but that would be a great idea to tie it into PTH measurements and metabolism too. I don't. That's a terrific question. These folks may know more about it. I've sat down with Jason face to face to try to see what he thinks about that, and I think he thinks it may be something intrinsic to the underlying genetics of metabolic syndrome, but I think that's a big area of interest in him. But I think it may be something to do with the syndrome itself, whether it's cause-effect, but I think it's one of the things that goes together with it. I think it's more than just the fact that those people may have increased adiposity. I think it's part of the biochemical derangement that is the metabolic syndrome.
Sweet. There you go.
I just wanted to know if there's been any research related to calcium and it's from dairy products in totally grass-fed dairy products versus standard.
I'm not aware of it, but I'm not saying it doesn't exist, but off the top of my head, I can't tell you anything about it.
Quick question. How often should you have your vitamin D level checked? If it's normal now, 5 years, 2 years?
I don't know. You know, and I really don't know because I don't have any data on that. I guess once I got on supplements and knew I was therapeutic, I don't plan on checking it again for myself unless it's part of a panel. I think that if you were low, I'll maybe avoid the word deficient, but if you were low and you took an initial replacement or changed your dietary habits or got outside, I'd check it again. And if you're well, after replacement?
Yeah, 3 months.
Yeah.
You have to have 3 months.
Yeah. And, you know, part of it depends at the time of the year that you check it, because you check it in January, it may be different but if you get well in the therapeutic range, at least for me, I don't feel the urge to have it rechecked on my patients or myself. But if they were to come back and say, oh man, you know, I'm disabled now, I can't get outside, I can't tolerate, you know, the supplements. I had one of my patients she claimed terrible problems with the things hanging up in hemorrhoids. And so, you know, if there's something that changes that you think the levels may drop, I'd be more interested in getting something from the IOM that maybe helped with that, which would be a very practical application of how to deal with this issue. But for right now, I think once you get in therapeutic range, you can't argue with every 5 years. I don't know that I'd check it every year. I would not.
In keeping with that comment, what we know about the importance of vitamin D, I'd just like to say I think we need to be advocates with the Centers for Medicare and Medicaid Services, because they are giving the message that this is a test they're not wanting to fund. And so I've had primary care physicians in Kansas tell me that they're not able to order vitamin D levels on patients. I suggested it for my 92-year-old father, and his physician said, I'm sorry, that won't be funded. Will you pay for it personally? And of course I would. But So this may be an issue with certain populations that are not able to afford vitamin D testing on their own.
Just to go back to the first part, is that, yeah, there are no guidelines at this time. But I think it kind of goes to the patient or the individual comorbidities and risk factors. So I see osteopenia and osteoporosis. So in patients who have vitamin D deficiency with osteoporosis, I do it generally every year. If they're stable, then, longer durations of time. And yeah, that is a big issue with the funding. And sad to say, you get it covered if you already have a diagnosis of vitamin D deficiency. So you first have to have a diagnosis before you can get the lab test. So that's just the way the government's working at this time. But I think that there are ways around it to get the code, to get the correct code to get funded. But I think that was a really sad aspect, because when you think about for osteoporosis, every single study that has shown benefit with the therapeutic drugs, they had to take vitamin D and had to be supplemented in vitamin D in order for any osteoporosis drug to be effective. So you need it in that population.
And that, for an overview, for a take-home thing, that's how I look at this too. There's a lot of things that all of us can do in our areas. A stress echo, $1,300. Many antihypertensive drugs are extraordinarily expensive. Lipid-lowering medications, some statins are generic now, but you can pay dollars per tablet for some statin drugs. Many populations, it's just hard to apply those public health measures to all of them. If you look at things that will do the most good for the most people, the old standbys that we know about: wear your seatbelt, don't smoke, don't ride a motorcycle, maintain ideal body weight. To me, things that are safe, have low evidence of toxicity within the ranges that we're talking about, but taking a vitamin D supplement in that range, in the dosage range we've been talking about, falls in that group of things that on a population-based basis, like putting folic acid in bread for neural tube defects, things like that are going to impact millions of people. And if there really does prove to be the associations we've seen persuasive in regards to hypertension and diabetes, hyperlipidemia, and vitamin D, holy cow, that's an incredibly cost-effective thing, I think. Hopefully there will be a finger stick type test. You can have your omega-3s checked now with the finger stick, just like blood glucose, but instead of being a $45 test or an $85 test, a vitamin D becomes something that's part of a $20 screening that you walk into Walmart for, and that within the limits of assay accuracy, you can get an idea whether further work is needed and whether you can maybe get paid for getting a mass spectrometry assay done in that case. So that, to me, that's the future, either broad-based public supplementation programs or very inexpensive screening, and that's maybe where we can make our money and retire, by setting one of those things up.
Well, it has been our pleasure to work with the Mid-America Cardiology and the KU School of Medicine in putting together this 2010 Kansas University Clinical Nutrition Seminar. And so I would very much like to thank Dr. Bosick and Dr. Bhattacharya, and they will be receiving what is appropriate, perhaps, from a Department of Dietetics and Nutrition, which is food. And this is real food, and by that I mean it is wholesome food. You're expecting this, but Dr. Bosick doesn't know about it. And so this is from a group of farmers from Cooperative Farm and from Good Natured Family Farms. And so we have about 12 items It's everything from the, yes, he's pulling out the tomatoes grown within 50 miles of Kansas City. There's living basil. There is delicious apples. There are whole foods like chicken and eggs and milk. And so this is for your family or your associates. And if he doesn't have a place to keep it food safe, this is good for 2 hours, but we will store it for you.
I'm quadruply as a Nebraska native and an incredible Nebraska Cornhusker football fan. This committee is from Nebraska, and I appreciate you wearing your red outfit, too.
Blue and red, okay. So thank you, all of you, for coming. We have evaluations. You can put them in the box on the table. There is more Calc C for the road if you want to take your calcium-fortified fruit beverage with you. And thank you so much for attending. There are tours happening at 12:30 if you want to congregate out by the tables, and our students will be showing you around campus. Come to see me if you want to know more about what's in these bags. I do not have a financial disclosure to make, but we just believe in sustainable food. Good sources of calcium. Farm to market bread with spreadable honey with comb in it. Okay. It's different.